Good evening, everyone. First of all, I would just like to acknowledge my other colleagues within the team, and also our other collaborating partners. As you've heard from the presentations earlier, you can see that there was a lot of collaborations between different partner institutions, different academic institutions, the Irish Hospice Foundation, the Institute of Community Health Nursing, and the Irish Cancer Society, and others. So I would just like to acknowledge them first of all. And in particular, I would like to acknowledge Rita. And Rita Collins. Rita was our programme manager. We started out with a different programme manager as well than Katrina, and we have acknowledged Katrina within the report. But Rita was really, I suppose, our project manager working with us for the last year. So I'm going to do it at this point so I don't forget, okay? So,
yes.
Rita, would you come up just please first? Just a small gift really, just to show our appreciation, and thank you. She didn't know that was happening, so. Really, I suppose you've been waiting in anticipation for the results from Ireland. I can see it's a wee bit like you've heard the European context, and now you're going to hear the Irish context. So the scores, we'll see if they come through. In relation then, just very briefly, I won't go, Bridget has given you significant background in the whole development, and as we've said, Bridget, we've worked in partnership with her over the last 2 years. This was very much tying in from, and you've heard the history of how this has come through from the Irish Cancer Society and our submission for really some funding to be able to take this forward. But some of the key aspects is that, as Bridget has alluded to, when we talk about dignity, it's quite an abstract concept. And what do we really mean and understand by the concept? And we talk about maybe dignity conserving care. You have more recently, if you look within the UK and in other systems, we can see the idea of conserving dignity and the importance. Well, what do we actually mean about that? And then also, as Bridget has indicated, and we didn't link on this, but we can see we've used the same reference, but that people at end of life fear their loss of dignity more than anything else. And also, but that dignity is quite unique for the individual and the person. And if we think about family-centred care, person-centred care, how we think about and conceptualise dignity is quite unique for each of us in whatever situation we can be in. And the palliative care, and we've heard about our definition of palliative care in relation to within a primary care context, but it is about assisting people to live and die with dignity. So it's more than just end-of-life care, it's also about helping people live. And you'll see, I think it's interesting, a contrast we have in relation to our sample for the sample that we selected in Ireland and some of our results, just focusing on that, and I'll allude to that shortly. And then also community care, and very much about the role of the generalist and the role of the generalist in palliative care. For a lot of the care and the care delivery, while we have specialist palliative care and the importance of the link between specialist and generalist, a lot of the care, again, is delivered by general practitioners, have a core role. Community nurses have a core role, and that we need to have a focus there because evidence indicates that people want to be cared for and die at home. They want to live at home. And so when we think of community care, that's in the broadest context. That could include nursing homes, residential care, so a broadest context of our definition of community. Then if we think about personhood and the idea, and this is coming through from Harvey's work, and Harvey, I'll not go through the details because Bridget has given you the background on who Harvey is in his work, but I think what's interesting is we know in terms of our essentials of care, we think A, B, C, and for again, those of you who are nurses or health professionals in the audience, you'll know about your airway, breathing and circulation and all of that. But the other context, our attitude, our behaviour, compassion, and dialogue, and really focusing on the question that what should I know about you as a person to help me to take the best care of you that I can. And I think the idea and refocus again on personhood is important. You've seen in terms of the background there and the key areas, so this is built on. So I think importantly, what I only just want to emphasise again and reiterate is the importance that this is built on substantial theoretical framework and theoretical work that's underpinning and this whole model that is there, building on from Harvey's work and then Bridget's further work that takes this on. And I think when we think of in research and maybe complex interventions and how we put interventions in, it is the whole theoretical methodological focus behind interventions is of vital importance as well. So really DCI Ireland in terms of it. So what the aim and what we were really trying to do was to implement and evaluate this dignity care intervention, which was going to be delivered by community nurses to help conserve the dignity of individuals with advanced and life-limiting conditions in an Irish context. So I will go through the criteria, but I think importantly, as has been alluded and Mary picked up, is it's very much included people who had both malignant and non-malignant conditions, and in our case as well, frailty and frail elderly. So again, what is it and what is the intervention? I think again what's important is the tool. We can see the tool and where it's built on. We do see the PDI, and we have a self-report measure that's there, and also reflective questions. So it's comprised of the manual and of all the elements, and Bridget has discussed that and highlighted that to you. So for us, in our context, we've seen very clearly that this was a service improvement initiative. So it was about trying to introduce something into practice that would be trying, and then having a process of evaluation around that to see, well, what difference or what impact, if any, was there with this tool. So we broke this down into different phases. So we had, first of all, the need to contextualise the tool to Ireland. So we might not think we're different in Ireland, but we are. So it's important when you think about the context in which you work and operate as well. So we wanted to go through a process of actually taking some time to contextualise it towards an Irish context. And that might be in terms of some aspects maybe of the suggested care actions weren't necessarily relevant, because if we didn't have that service here, we couldn't say do a referral to Marie Curie nursing when that service isn't available within an Irish context. So part of the process that we did was that, I know some of our Voices for Care representatives are within the audience tonight, was that we undertook a focus group with the Voices for Care group, where we really talked about the DCI project and the intervention, and we sought their perspectives on the language that we use, the words that we use. If this tool was to come through and if their context and from their previous experience, how they would think about it. And then we also undertook some focus groups with our community nurses. I think it's important, again, maybe the majority of the audience here are from the south of Ireland. Within the south of Ireland, you have public health nurses, which is quite different than maybe community nurses we have for district nursing within a UK context. So the terminology we're using for community nurses includes both public health nurses and community RGNs. And then we wanted to update the evidence and look at the evidence around the care actions, and that was the third piece of that work. Then phase 2, which was about the educational programme, and that was delivered for community nurses, and my colleague Dr. Michael Connolly, who's also in the audience, led on that piece of the work that was really about looking at the manual, looking at innovative approach of how we actually deliver the educational programme, having an educational platform using the platform that we have within the Institute and the Palliative Hub. And then we had to implement it within 4 pilot sites, and I'll talk about those. And finally, we had the focus around evaluation and different strands of the work that led and contributed to our evaluation. So in relation to contextualising, some of the key findings coming from the community nurse was that dignity was about listening to the patient and listening to the family. Whenever we spoke to the users and carers, they really very much linked dignity to respect, and to respect the person just because they have a life-limiting, they're no different just because they have a life-limiting condition. And then also about this normal activities, maintaining a normal life for the patient. And I think it's interesting when you look at some of the categories there within Harvey's framework, that this idea of normality is important. And as Bridget alluded to, this was recently the care action piece we've just had published earlier this year in Journal of Clinical Nursing, sort of updating the evidence that Bridget had previously worked on there. Phase 2 then, we had our educational programme, which was delivered for the community nurses, and they were derived from the 4 pilot sites. And the educational component really comprised 2 elements. We had an online programme which was really about a general brief introduction again to palliative care, and then focusing more specifically on the DCI Ireland and background information on DCI, a bit about the care actions and all of those elements and components actually of the intervention. And this was also aligned, we had facilitated workshops which followed the online programme, and it was about trying to use and I suppose to bridge the gap that we might have between education and training and then implementation. So it's fine that sometimes we have courses and educational component, but it's important that people can apply that and can apply it to their context of their practice. So we tried to use different case studies to aid implementation of this actual intervention. And this was, we undertook an element of evaluation here, both pre and post, just assessing knowledge and understanding. And what we did find was that post the educational component, that we could see clearly an increase in knowledge and understanding, and that was about palliative care and dignity conserving care and what we mean. But we could still see in terms of the evaluation it was looking at, there was difficulty in actually making the application in practice. And that might be less of a surprise to some people in the room, but it's this whole application and moving it into practice that is important to still be trying to target. So with relation to our implementation, across the island we selected 4 pilot sites. Now we pulled together, I suppose, within the time here, I can't go into all the detail of how, but we had various meetings, and I know that various members of our steering group are here and our project group are here. But so we had to make a decision, where would we pilot this? And we agreed that we would pilot it in 4 areas. Now it wasn't just we picked them randomly, we tried to pick that we had both rural and urban areas. But in terms of their locality size and their practice population, they were similar. They were also similar in terms of the number of PHNs and the staff that they had within the areas. We definitely wanted rural and urban. We wanted, that was a key aspect, but we wanted comparability as well around the sites. So we selected sites from Limerick, Wicklow, Dublin South Central and Dublin South City, and they were our sites. We had to select and consider, we also reviewed the criteria for who this tool and this intervention would be with and what type of patients we would include. So we included advanced and life-limiting conditions. We included, as we've said, both malignant and non-malignant conditions. But particularly for the public health nurse caseload, there is a big caseload of frail elderly. And I think that's important, and maybe to take in context of maybe some comparative work or differences that whenever you can see Bridget's tying through, but you can see that this work could be undertaken with people who are, dying and actively dying, or maybe more towards end of life, and maybe not just at the very last stage. But we had people who were on the caseload with the public health nurse for over 2 years, and they were selected. And so the idea that we would also have frail elderly patients as well. We did have, and there's no surprise, various implementation issues. So we undertook the educational programme, and that was very much moving towards, okay, want you to use this within practice. But within this, it comes across challenges. And there was differences in how the nurses and the teams would identify and recruit the patients to participate within the project. So for example, we could see, and it was more whenever it came to the evaluation, we could see that within an urban setting, for example, because of the nature of how the role works out and how the work is constructed and organisational issues, a lot of the identification and targeting and recruitment of patients was undertaken by a community RGN, because they work within that aspect and they form part of the team. Within the rural sites, it was largely the public health nurse who helped in recruiting and identification of patients. There are just differences across the actual organisation in relation to the role of the public health nurse and how it's implemented, but this also did come into how the project and how they were recruited. We also had gatekeeping issues in that very much people were, whilst we identified the criteria that were there that people would be eligible to participate and not participate, what happens, and it's no surprise for people who do research, is that nurses apply their own criteria. They also apply additional criteria, or they interpret that criteria slightly differently. So it is important, because then while they say, is that patient suitable, they sort of think, well, maybe not today, or something else. And sometimes those reasons can be extremely valid, in that there could be something else happening that maybe we don't know about. But I do think it's a challenge, and it's a challenge that's recognised within palliative care research. And it's a challenge I think we have to give ourselves as healthcare professionals as well. Sometimes we can be quite paternalistic in making those decisions, as opposed to giving those decisions to patients and families to make. And we also had some variation in concerns about recruitment, about, again, the identification, as I've said. So that they were issues about implementation. In thinking of our evaluation, we very much built this around the methodology of realistic evaluation, which is very much focused not so much on just, it's focused on the outcome and trying to get, well, did it work or did it not work? But it also focuses on the process and what works for what people in what circumstances. So it also values the process as much as also the outcome. It did tie in very much, and it sort of builds on, I think, as Bridget has alluded to, the need to move to something much more, other methods of approach, I suppose, for evaluation. We still did very much depend on quite a qualitative approach as well. So we looked at the completed tools that we got back from the patients who had used it. So I have some analysis, and that's within the larger report, of the completed tools and trying to see where the major problems were. We haven't really broken it down in terms of malignant, non-malignant conditions, because really for the numbers that's quite difficult to do, but it might be worthwhile considering, but I don't know how much we could pull out of that. We also undertook patient and we tried for patient care interviews. Now, on some occasions there were some joint interviews, the majority were with the patients, but we had 18 interviews, and then we had focus groups with the community nurses who used the tool. And that was across the 4 pilot sites, and in total, so 4 focus groups and 24 participants in total. And then we followed up with an online survey with the public health nurses, because we were conscious that maybe some people couldn't attend the focus groups, some people hadn't used it, and we weren't really sure what the reasons were, and we wanted to give that opportunity as well to just try to close off if there was something additional that we had missed that we needed to try to find out. In relation to the analysis of the completed tools, we had 27 patients who had completed the tools. So whenever they undertook, the nurse introduced the tool, and there was a whole process about how all that happened. A copy of the tool came back to us as well around the actual completion. And so we had that for 27 patients. You will note that we had 18 that were interviewed. There was various reasons. Some people between the time of the completion of the tool, there were a few people who had died, other people had changed circumstances, some people declined, and that again, there's different details. So we interviewed 18. It's interesting that out of the 26 statements, that almost 50% of them were deemed not to be a problem for these patients. Of the largest area that were concerns, it focused around the illness-related concerns. And for this came through the physical symptoms, which was focused around pain. Another key area that came through was around a higher area around the dignity conserving repertoire section. And it was this sense of not having control over their own life. In comparison, though, in the social dignity inventory, the majority of the patients that we had reported no problem or a slight problem in this area. So this does raise questions for me about the sample and the sample of patients that we had. Later on, I don't think I have the slide up on it, but as I've said, the majority of the patients who were recruited to this particular project had been on the caseload for over 2 years. So, and the nurse had whenever the feedback was that they wanted to have a relationship before they felt they could introduce this tool. So there was a reluctance still. So there was an element of recruitment there and the identification of a sample, and I do think that raises some questions for us to consider and compare. So in terms of the patient profile, you can see the demographics, that the majority were within the 75 to 84 age group, that the majority either lived alone or with the partner, that they did have a comorbidity, so that was flagged up, and then the different diagnoses that they had. In the patient interviews, we asked them very much around, we're trying to get their view of using this tool, and you sort of have to talk around their idea and their perception of dignity. What very much came through was it was difficult to keep it around the tool with separating out dignity and the 2 elements that were there. But whenever they talked about what dignity was and what was important to them, it very much was focused around the need to have control, and that focused around the personal care tasks. So that was the biggest concern they had, that they were in a situation where they were dependent and relying on other care, and some of those aspects were affecting their privacy and their dependence on other people. In relation to the perception of the tool, it was interesting that they had no concerns and no problems when using the tool. And they had a real openness to discuss concerns. And I think, again, as Bridget has highlighted, that number 26, which was worried about how your illness and death will affect your family, the nurses had a great reluctance in discussing and considering this element, but the patients didn't. They had a real openness to this, and they didn't have a concern in trying to have this discussion, and that was explored at interview. For the nurses, whenever we talked through with them in the focus groups, we took through what their perceptions of dignity were, and they talked about meeting the person where they were at, respecting their wishes, maintaining well-being, and also involving the patients and families in the decision making. Whenever it came to actually unpicking, I suppose, in a sense, or trying to pull out the use of the tool in practice and what actually happened, 3 key themes came through. And it was a sense of, and this was almost like whenever we did the focus groups, that on the reflection that the nurses had afterwards, that they felt that they perhaps did pick and choose too carefully. And it really just seemed to dawn on them within the interview, within the focus group interviews. They said, well, maybe we were picking and choosing too carefully. We were being cautious about who we'd actually choose to do it. Gives us evidence around our gatekeeping, which we knew anyway, but also it was important to see the enlightenment whenever they were thinking through in the focus group discussion. There was the idea that it was very much about a piece of paper and a tick box exercise, and that concerned them, and they had some issues around how, and that related maybe issues how it was introduced and considered, or maybe what they felt about it. But this was the biggest theme, was about opening a can of worms, and that came through from all the focus groups. That they had this idea that once you open the can of worms, you can't just leave it, and this has the idea of opening a can of worms, and that created some anxiety and reservations for the nurses, and that tied in then to some of the challenges they had about using it, which were focused on their workload, time, and also they had a sense of not feeling prepared for some difficult discussions and conversations. But the converse of that was that, again, they felt that it raised the profile for what they actually did anyway, and this is the care that we're delivering, and that it could be a great opener or an aid or a tool for other conversations. We followed up then with an online survey, and as I've said, we had not so much of a response rate. We had 30% response rate, which can be acceptable for online, but it was 27 participants. The results would indicate that the majority of those who completed this agreed that it was a useful tool for community practice. They had some concerns, however, about the overall length of the different items, and I think that's important to acknowledge and indicate. They agreed and that the tool had contributed to the assessment of palliative care patients. It had initiated other discussions, and it had identified areas of need that would not normally have been met, and it had initiated new care for their patient. So even in that, while they could indicate and they could cite clear examples, we also had that within the patient feedback that there was, it triggered some conversations within families that some of the patients and families had to undertake, that it reminded them of certain aspects. So for example, there was one patient who had a child with learning difficulties, and they realised they needed to have a conversation. Some of the positive aspects were very much around the communication, and the idea that this is a useful tool to focus and support elements of communication and the assessment process as well. Challenges were focused around the time and resources, and also lack of knowledge about the patient, so that might indicate also and reinforce the idea of the selected particular patients to use it with. So really, in terms of conclusions then, that overall the patients and nurses were supportive of the use of this tool. They seen it very much as it helping to identify new areas. So it did contribute and open conversations that previously might not, and new concerns that might not have been raised. The nurses expressed concerns about discussing death and dying, and this related to wider organisational aspects related to their role in this context. So that ties in with some elements of the public health nurse role, community RGN role, and those elements of their role as well. But that they felt that it was important to focus on respect, privacy, autonomy, and sense of self. So in conclusion, some recommendations that are coming through was very much the need for education about talking for the nurses when they were talking to patients and families about death and dying and end-of-life care. There's a need for further consideration and analysis of the role of the public health nurse within the Irish context in palliative care, given the time constraints and the diverse workload that they have. The patient need for dignity in all aspects of their care needs formal recognition, and that there's a need for the formal assessment of dignity as part of the overall patient assessment, so that the issues that we've identified are more routinely incorporated. There is an element that it does contribute and brings up what they do anyway, but it needs to have an evidence that is incorporated within the patient care, and an education on dignity conservation using existing resources. The full report and the executive summary is available. I encourage you there, and just like to thank you. Thank you.